Sure, sure. Thank you.
Right, so we are again. It's a pleasure and privilege to have you with us, Girish sir, and we have thoroughly enjoyed your last outing with us. So our postgraduate students have hopefully learned quite a lot. So we would like to continue your
Yeah.
lecture. So we'll hand it over to you, sir.
Sure, sure. So what I'll do is, I mean, since I think it is better to cover a smaller topic in a broader way rather than, lot of topics. That's why I said, let us split this into 3 talks rather than, So today we'll just, I'm audible, right? I'm easily audible. Okay.
Yeah.
So we will just talk. I mean, this will be a very practical, what you have to do in the ICU sort of talk, using all the knowledge you got from the first talk. Yeah. So I'm just going to share the slides easily visible.
Yeah. Perfect.
Okay. So we will talk about the actual case scenarios of different types of lung diseases, and this will be probably what you will be actually seeing in the pediatric ICU. In fact, these are actual cases, if I have to say, with little modification for teaching purposes. So we will start with this case, and it will be interactive. So I would really want postgraduates, whether it is wrong answer, right answer, don't worry, but just keep answering, right? So we will start with this child, 3.5-year-old child, comes with history of ingesting about 25 ml of kerosene. He comes to you about 30 minutes after ingestion. He's having cough, incessant cough, rapid breathing with intercostal and subcostal retractions, bilateral crepitations. Saturations are 94 to 95 with 5 liters of oxygen. You are seeing in your emergency room. So what does your postgraduates want to do? What is the next step, immediate step for this child?
Yeah. Subhash, yes. So I would like to be louder.
Can you take, is there a mic or come near? I can't hear.
So, what do you want to do, Subhash?
As in, this is a hydrocarbon poison. There is no role of gastric lavage or gastric lavage. So the baby is being stabilized with 5 liter oxygen and he's maintaining saturation above 94. But the cost of work of breathing is high, and also there is intercostal and subcostal retractions. It needs some support, sir. I would like to escalate the respiratory support by giving HFNC or the next mode of ventilation. This nasal pumps oxygen is not.
Sorry, I couldn't hear Vikram. What he said, I couldn't hear.
So
because I think
what he says is that the child has increased work of breathing, currently on low flow oxygen. So first he would, after having taken care of ABC, he would want to hike it up to high flow nasal cannula and then continue monitoring.
Okay. And also he said no gastric, no lavage. That's a good thing. Yeah.
No gastric contamination.
Absolutely good thing. But you'll be surprised like how many people we used to get, how many kids we used to get with actually gastric lavage being done. So definitely it is a contraindication for gastric lavage. And you'll probably, yes, you will. Where will you admit him? You will admit him in the ward or ICU?
ICU, sir. ICU, sir.
In the ICU.
Step down ICU, PICU. PICU care needs.
He would definitely.
So see, within 30 minutes of ingestion, he's so sick. So definitely this child is potentially going to be more sick. So it is better to admit in the ICU. Yeah. So these are the 3 choices. What do you want to do? Or, I mean, what you said is also right. You don't want to do anything, in the sense you don't want to intubate and ventilate as it. You don't want to get a blood gas. That's okay. Blood gas is not going to add too much to the management. NIV? You want to do NIV for this child?
Yes. He's conscious, he's
I would not probably do NIV for this child because, you start NIV and he's going to, vomit again, whatever is there in the stomach, he's going to aspirate more, right? I would stay away from NIV in this particular child I'm talking about. If this is the same child with just pneumonia coming with this, yes, NIV could have been an option,
Okay.
right? So what you said is right. You just admit in the ICU, monitor him. That's okay. It's a reasonable choice. Okay. Now, always look at the, go back to your physiology and see. As you can see, this is in the x-axis is your PaO2, y-axis is your saturation. And as you can see, around 60 of PaO2, beyond that, the saturation doesn't change much. But when the PaO2 comes down from 60 to 40, there is a rapid drop in the saturations, right? So 93, 94 saturations does not mean that he is out of danger, right? I mean, you may not need to do anything right now, but what it is telling you is he is right at the verge of this drop. So little more lung disease, it's going to quickly drop to 80, 85. So if this child was saturating 100% and 100%, I would have been more happy. But he's 93, 94 on 5 liters. So he's right here. You can see my cursor, right?
Yes.
Yeah. So he is right here, and anytime it can just plummet. So this is a very critically ill child in the sense he's on the verge of getting worse. So better to admit him in the ICU and monitor. You don't need to do anything right now other than probably continuing 5 liters or maybe 8 liters, maybe 10 liters non-rebreather, or HFNC is fine. It's an idea you can implement, no problem. Okay. Now, after a while, somehow you did an ABG. This was the blood gas, right? What would you do now? Somebody had done a blood gas. I would not have done a blood gas on this child because, okay, you can monitor him without a blood gas. What would you do now?
Continue monitoring.
We already discussed, right? Yeah, admit him in the ICU and monitor.
Yes.
There is no immediate necessity to ventilate this child yet, right?
Yes.
3 hours later, his respiratory rate is 70. Now he's on 8 liters oxygen. Saturations are 92 to 93. Let us say, because you already told me that you wanted to put him on HFNC. Now let us say he is on HFNC. He is about 15 kilos and you have put him on HFNC of 30 liters and his FiO2 is 70%. And this is what his condition is, right? Let us change the question a little bit because you wanted to do the HFNC, which is a fair choice. You are on HFNC and now he's on HFNC 30 liters, FiO2 of 70%, saturation 92 to 93, respiratory rate of 70 per minute. What do you want to do?
Then another ABGs.
Do another
Another
ABG is
ABG.
what they want.
Okay, ABG, how does it help you in deciding? Because see, I'm not a big proponent of too many ABGs, right? Because now you have a gadget like saturations, you can check. So there is really, okay, so why do you want to do an ABG?
We can get
Let us say his pH is 7.36, PCO2 is 38, and his PO2 is 65.
We can get to know the severity of ARDS by checking the PF ratios. Whether it is moderate ARDS.
Okay. But you can also, but tell me, without doing a blood gas, with this clinical scenario, he is breathing at 70 per minute. What in 3 hours after the ingestion, what do you think is going to happen for him in next 24 to 48 hours?
Is hydrocarbon poisoning, it is chemical pneumonitis, and it can progress really.
He's going to get worse, right? He's going to get worse. So your
Yes, sir.
decision to intubate here is fully clinical, right? You think that he's going to get worse, you can as well go ahead and intubate this guy rather than getting a blood gas. Blood gas really won't help so much in this. Of course, it will give you the quantification of PaO to FiO2 ratio, and so that you know whether it is a moderate ARDS, mild ARDS, or severe ARDS. Most likely, this will be moderate or severe ARDS. Irrespective of a decision to intubate will be completely clinical, right? So you can continue to watch for a few hours. That's okay. That's a fair decision. Or you go ahead and intubate and ventilate. Suppose this was at 10 in the morning. I have just come to ICU. I know that I'm going to be in the ICU for next 7-8 hours. I will probably watch for a few hours, get everything ready for ventilating, but I may not ventilate. But if this was at 11:30 in the night,
Yeah.
I would rather intubate this child, ventilate this child, because I know that he's going to get worse, right? So ultimately, it is your clinical decision, really. And 3 hours after the disease, it is so bad, and he's going to get worse. He's not going to get better any soon. I mean, nothing you can do for managing this patient, in the sense there is no specific therapy. Next 48 hours, his inflammation is going to get worse. So he's going to get worse. So you can wait and watch for a few more hours. That is okay. That's not going to put him in danger. But or you can just intubate and ventilate. So getting another ABG is not really necessary. Either you do 1 or 3, right? Any questions or any comments, or you want to do it differently?
No, I think that's fair. Absolutely.
Yes.
All of us agree with that.
Yes.
Again, it's
Yes.
breaking. Voice is breaking. I don't know. Maybe the mic issue or something.
Yes, I mean, we don't have a mic, so I am directly talking into the laptop. So probably that is what is causing the problem, sir. But
Your
you
voice
are
is breaking, Vikram.
Yeah, well, the problem is we don't have a mic here, sir. I'm directly speaking into the laptop. So
Oh, okay, okay. Maybe next time you can arrange a mic. But probably it's easier. Yeah, because
I'll do
I mean
that.
it's so breaking so much that I can't make out.
No, you are absolutely
Okay. So we'll go to the
and,
next one.
Yes.
Okay. Now, so his next ABG, as you wanted, I have given the ABG, PCO2 of 48, PO2 of 62, and base deficit of -2. Right? Now, what are you going to do?
Intubate and ventilate.
Yeah. So here definitely, if he is breathing, remember, always the blood gases have to be seen in the clinical context. He's breathing at 70 per minute, and his CO2 is 48. That's not a good sign, right? That's not a good
Correct.
sign at all. If he was breathing 10 per minute and his CO2 was 48, that was a different issue. So not only oxygenation, his CO2 is also quite bad. I have given you the blood gas, but as I said, ultimately the decision to intubate is clinical in this situation. I would not do too many blood gases for this child. If he's getting worse, oxygenation, he's requiring more oxygen, you go ahead and intubate. Okay, you decide to intubate him. You intubated him. Okay, now what are you going to do? What are the choices? What do you want to choose? You successfully intubated with a 440 tube because you couldn't find any other tube. Next tube was 6. So he is 3.5 years. So 4 size tube you urgently put in. You have asked for a different size tube. It is not there in the store. And now bilateral air entry is good. You even confirm end-tidal CO2. What mode are you going to use?
So is it a cuffed or an uncuffed tube, sir? Cuffed tube, right?
Uncuffed tube. That was the only one which was available.
Oh, uncuffed. Otherwise,
I have put an uncuffed tube.
Ideally speaking, it should be cuffed, right, sir?
Yes, it should be cuffed, but it was not available. So they said they will get it in hours.
Okay, so which mode?
Pressure support.
So they say pressure support.
Why pressure support? I mean, you have given him sedation, you have given him paralytics for intubation, right? Remember last time we talked about pressure support is like you have to be spontaneously
Right.
breathing, right? Of course, if you put on pressure support in certain ventilator, automatically it will become pressure control ventilation if you have paralyzed the child. Yeah, that is fine. So pressure versus volume, which one?
Volume limited.
Why volume limited?
Has to be pressure limited. I mean, I'm just telling you the answers that they're getting, we are getting.
Ideally should be volume limited, but that uncuffed here is.
So they say because they've used an uncuffed tube, so they would go with the volume limited ventilation.
Oh no, that is exactly the reason why you should choose pressure, right? Because if you are volume limiting, that means you are giving 200 cc of tidal volume, 100 cc may leak out. For
Correct.
that reason, you should be on pressure limited. Because pressure limited means you are saying, okay, let us say PIP of 25, it will give you 25 irrespective of the leak.
Correct.
So that is also another reason why you should be on pressure limit. So apart from that, what is your aim of ventilation in this child? What's your aim?
To maintain, keep open the alveoli.
To keep the alveoli open.
Sorry?
To keep the alveoli
Yes.
open.
And also, see, aim of ventilation in this particular child, or any, for example, for aim of ventilation in anybody, is to keep them alive till the lung recover by itself, right? That's the
Yeah.
basic aim of the ventilation. Now, in this child, if his PCO2 goes to 55, 60, will you be worried? Is it going to harm him?
Yes.
PCO2 I'm talking about. You are on a ventilator and his PCO2 is very like 55, 60. Will it kill him?
Will not kill
What
him.
is going to
but
kill him? Hypoxia or hypercapnia?
Hypoxia.
Hypoxia.
Yeah, hypoxia is going to kill him, not hypercapnia. Plus, a pneumothorax or an air leak will kill him. So,
Yeah.
that is why I would do pressure limiting. Second reason also because it is a leaky tube. ET tube is small. And the third reason also because we talked about time. What is the type of flow in pressure control ventilation? Is it constant flow or decelerating flow? It is decelerating flow, right? So when you have a decelerating flow, that means it reaches the top and comes down, which is better for a disease where it is in. See, the lung disease here is heterogeneous in the sense there are some areas of lung which are good, some areas of lung which are bad, which have kerosene. So there will be different compliance in these areas. So it is better to have a decelerating flow so that there will be better distribution of gases. So for all these reasons, pressure limiting is better. Okay.
Yes, sir.
So in nutshell, if I don't have to care about see, when you say volume limitation, that means you are telling the machine to give certain volume and certain rate so that minute ventilation is constant. And you have to do that only when your primary objective of ventilating the patient is to normalize the blood gases. For example, a child with head injury, where you don't want CO2 to be high, or a child with pulmonary hypertension, where you don't want CO2 to be high, then probably better to do volume ventilation. Otherwise, in ARDS, pressure ventilation is better. But of course, we talked about PRVC mode last time, which does volume control, but it does pressure regulation. So that is a better mode, of course. It combines the two advantages of the two. But pressure limitation will be better in this child because of three reasons. One, leaky endotracheal tube. Second, it is a lung disease which is not homogeneous. So better distribution of air because pressure ventilation has decelerating flow pattern. And here, your aim is to avoid high pressures. Because if you start volume limiting ventilation on this child, And if his lung disease gets worse in next few hours, his pressures will be very high because you're not limiting the pressure. And you're right. So you need to start with you limit the pressure. That would be better. You got
Yes,
the
sir.
point, or any questions, Vikram?
No, absolutely. Yeah, we got the point.
So now we choose the pressure limit for that reason. So what settings? What are the settings they want to try this child on?
Okay.
He's a 3.5 years old child. So what is the respiratory rate you want to start him on?
Around 30.
30, okay, reasonable. 24, 30 is fine. I would say probably 24, but yeah, okay, 30 is fine.
Okay.
IE ratio of 1:2.
IE ratio of 1:2.
1:2 at least, yes, correct. Okay, 1:2
1:2.
is fine, fair enough. Then, no, you're not choosing the tidal volume here, right? You're pressure limiting. PEEP.
PEEP of 5.
PEEP, positive end
Yeah.
expiratory pressure.
Yeah. PEEP of 5 to 6.
5,
5
5
to
to
6.
6. Okay, okay. What else?
Okay. PIP.
What else? PIP?
PIP of 14.
How did you come out of that number? PIP of 14. No, that's okay. 14 is fine. 14 in the sense, total of 14 means the delta pressure is 9, right? 14 of PIP, 5 of PEEP.
Yes.
So delta pressure is 9. But how did you come out with that number of 14? We don't know, right? We don't know how to come up with that number. But when you start on that, what you look at is you look at how much tidal volume the patient is generating.
Correct.
Correct?
Correct.
So then see if it is 5 cc per kilo or 6 cc per kilo. If it is 6 cc per kilo, it is fair enough. Correct? That's how you adjust the PIP.
So you'll have to slightly go back.
Before the advent of all these modern ventilators, we used to just look at the chest rise and adjust
you'll
the
have
PIP
go back.
according to the chest rise, good chest rise.
Yes.
But now we have the ventilators where you can measure the volume.
So sorry, you'll have to slightly go back.
Okay, so
Like,
oh, okay, yeah,
yes.
better.
Yeah, absolutely. Yeah.
Okay, so your voice is still breaking, Vikram. I don't know. A lot of times when you ask questions, I can't make out.
Oh, I'm sorry. I'll fix it. I'll fix it, sir.
Yeah, maybe you can take an external mic into the computer.
And I'll do that.
Maybe you have a- yeah. So you choose the pressure limiting. So now these are the settings we started. PIP of 20, PEEP of 6, respiratory rate of 24, I time of 0.6. So I time of 0.6 means what is the E time?
1.2.
So rate is 24. So each cycle time is what? Cycle time is 2.5 seconds, right? 24 it means 2.5
2.3
seconds is each cycle time. So I time is 0.6. So yeah, I time is 0.6. So E time will be 1 second. Just answer this phone call. 1 second.
Then I could really care some. Then we'll have to try. ಹೇಳ್ಸೋದು ಇಲ್ಲ ಅಂತಂದ್ರೆ ನೀವು ಒಬ್ರು ಯಾರು ಲಾಗಿನ್ ಆಗ್ಬಿಟ್ಟು
Recording in progress.
Hello. Hello.
Yes, sorry, that was from the hospital. Sorry. Yeah. So, oh, sorry. Oh, where did I go? Okay. You can hear me?
Yes.
Okay. So, so now we are doing 1.9 of E time. So this is almost 1:1.3. I mean, 1:3 IE ratio, right? His saturations are 98. As you wean his FiO2 to 80%, his saturations drift to 92. His X-ray shows diffuse whiteout, like ARDS picture. His ABG is this. And his inspiratory tidal volumes on the ventilator are 100 ml. Expiratory tidal volume is alarming on with tidal volume less than 30. What do you do next? Sorry, I gave away the answer in the slide. I mean, by mistakenly, I pressed the next button. Yeah. What do you do?
Change it. It's very excessive leak. Use of no.
So they are saying change the tube because there is excessive.
Yes,
leak.
absolutely. Because this child is going to get worse. With this leaky tube, you are not going to ventilate a ARDS patient. So it is better you get the right size tube, cuff tube, and change the tube. No question about it. So change the ET tube to 5, even if it's cuffed, or 4.5 cuffed is also okay, or 5 cuffed. Yeah. So he successfully changed the ET tube, and his saturations improve momentarily. Now inspired and expired tidal volumes are same. So that means you have taken care of the leak. However, he continues to be in the range of 90 to 92% with 80% FiO2. What do you do next?
They would look at all the other parameters, not just the ventilatory parameters. They would look at the circulation and then
Look at that. Sorry.
Look at the circulation part of
No,
it.
no. Hemoglobin. Why do you suspect anything about hemoglobin? Why do you think his hemoglobin will be affected? Look at the ventilator. This class is about ventilators. So only look at ventilator.
Look at the chest raise.
So what do you do on the ventilator? What are you going to change on the ventilator to make him better?
They want to increase the inspiratory pressure.
Sorry?
They want to increase the
Sorry?
PIP, inspiratory pressure. They want to increase the inspiratory pressure.
Increase the what? Increase what? Increase
Inspiratory
the
PIP.
No, why do you want to increase the PIP?
Because
What is your concern here mainly? Oxygenation or ventilation? Oxygenation, right?
Yes.
Your highest concern should be that he is requiring 80% FiO2 to keep the saturations 90 to 92. How are you going to get that FiO2 down? What are you going to do on the ventilator, which is going to help you in bringing down the FiO2? See, last time we talked about, right, the concept of PEEP. You have to increase the PEEP in this child. Correct? Because now you are ventilating far lower than the functional residual capacity. His functional residual capacity has come down because all of his alveoli are filled with fluid, inflammatory fluid. Correct?
Yeah. Yes.
So how are you going to increase the FRC? By adding PEEP. In fact, when you started the PEEP of 5, there is one way of doing is start with 5 or 6 and slowly go up. But what I prefer is in this kind of situation where it is given that, you know, his lungs are white out, I would rather start with a PEEP of 10 or 12 and then slowly come down.
Oh.
I will start with a 10 or 12 PEEP, FiO2 of 100%, and then come down the FiO2 to 40% and then start weaning the PEEP. That's one way of doing it. But this is also okay. Starting with 6 is okay. Starting with 5 is okay. But now here, the only thing which is going to increase his oxygenation is increasing the PEEP. Got my point?
Yes, sir.
PIP is not going to help him. PIP is only going to help him to improve the tidal volume, which is going to reduce his PCO2. We are not worried about PCO2 here. We are worried about oxygenation, right? So what is the next
Correct.
step you would do? You would increase the PEEP. Now he is reasonably stable overnight with moderate increase in ventilator settings. In the morning, he is on PIP of 26, PEEP of 8, FiO2 of 70%, respiratory rates 24, I time of 0.6, and his ABG shows pH of 7.3, PCO2 of 50, PO2 of 61, base excess of 2. His chest X-ray still has bilateral diffuse infiltrates. What would you do now? What are you worried about in this in this slide? Which is one number you are most worried about? What are you most worried about in this slide? Which number?
PO2.
Okay, PO2 is low. Okay, what else?
pH.
pH is okay. I mean, 7.3 is all right. See, he's still requiring FiO2 of 70%. That's what I'm worried about, right?
Yes.
Is such a high FiO2 requirement is the most worrying thing. So how do you get the FiO2 down? Again,
Increase the PEEP.
you got to increase the PEEP. That's why I said usually what I follow is I start with a high PEEP, 10, 12, recruit the lung and then slowly come down. That's a better way of doing it. But I just put in these slides so that you can. I mean, it's okay to start with 6, but he should not have been overnight continue to be like that. The main aim within the first few hours of ventilating any patient is to down the FiO2 down to 40-50%. For that, whatever it takes to increase PEEP, you should do, right? Okay. So what is the next step here? I would probably increase the PEEP to 10, and also increasing the I time, right?
Okay.
How does increasing the I time helps?
The area under the curve increases.
Yes, who said that area under curve? Very good answer. Yes. Now, basically, when you increase the I time to 0.7, that means you are increasing the time spent during higher pressure. So obviously, your mean airway pressure is going to go up. That is the area under curve, right? Your mean airway pressure, just like mean arterial pressure, right?
So please go back, sir.
Oh, sorry, yeah. So mean airway pressure is going to go up. So mean airway pressure going up means better recruitment of the lung and better oxygenation. So you can do this also, 3, increasing the I time, because we saw that his rate is 24. So and with a I time of 0.6, actually his IE ratio was 1:3. So by increasing to 0.7, you will still be within 1:2. So you can increase the I time even to 0.8, which is okay. If you increase to 0.8, he still has about 1.6 of E time. That is, he will be still 1:2. So I would rather increase to 0.75 or 0.8 also. That's okay. That will increase the mean airway pressure, which further improves the oxygenation. Increasing the PEEP will also increase the mean airway pressure. Again, area under the curve, because the PEEP is more. Now, why you don't want to, why not 1 and 2? With this slide, why not 1 and 2? His rate is 24. By increasing the rate to 30, all you will achieve is probably you can get down the PCO2 down, right? But that is not your aim. You don't need to do that. Because remember, if you increase the rate to 30, correct? Your IE ratio with this will become less than 1:2. So you don't want to increase the rate unless you're really, really, really worried about CO2. We are not so much worried about PCO2 of 50. And PEEP also same thing. If you increase the PEEP, what it is going to do is it is going to increase the excursion, lung excursion. That is what is going to cause the pneumothorax. You don't want to make the lung go like this, like this, like this, like this. You want the lung to be just like this, right? So very, very important that you are going to increase the I time, and you are going to increase the PEEP. So this is, the whole radical change came in 2000, adult study, ARDS network study, because people used to ventilate ARDS patient with 12 cc of tidal volume at that time, with a lowish PEEP like 4, 5, 6. But then then this strategy of keeping the lung open and then low tidal volume. Not like keeping the lung collapse. You can see my video.
Yes.
Yes, sir.
Okay.
Yes.
So keeping the lung like this and expanding like this with every breath is bad, whereas keeping the lung open and small excursion, this is better for the lungs rather than this. So you don't want to do this. What you want to do is, got it?
Yes.
Yes.
Okay.
Don't.
But the problem with that strategy, is it is good for the lungs. It is good as far as lung injury is concerned. But when you give low tidal volume, obviously your low tidal volume is low minute ventilation. Your CO2 is going to
Build up.
rise. Correct? But now we have realized actually high CO2 is not bad at all. It is not going to cause any problems. Right? So the aim of your ventilation in this child is to keep him alive and not cause any more lung injury from your side. Already whatever lung injury is caused by kerosene is already there, and you don't want to add it to it, right? Add to it. So large tidal volume, high peak pressures induces neutrophil activation. These are all very well known from lab research. Epithelial and endothelial injury, more excursion of the lung, more stretch injury causing epithelial and endothelial injury. So that is why now what we do is open lung, keep the lung open and minimize the stretch. That should be the strategy. So philosophy is, now too much of O2, too much of a good thing is a bad thing, and also too much of a bad thing is not so bad. Actually, that's what we have realized. So we know that hyperoxia injury, right? If you keep him on 70, 80, 90% FiO2 for more than 6 to 8 hours, that causes superoxide induced lung injury. And we have also realized that keeping CO2 60, 70 is not going to harm his lungs or his brain unless he has a increased ICP situation. So in this case, there is no increased ICP situation. So letting CO2 little up is not bad at all. As long as the pH is more than 7.2, 7.25, it is okay to let the CO2 climb. So that is the concept that evolved out of that 2000 study, and that's what we follow nowadays. We don't really chase the CO2.
Okay.
Any questions, Vikram, or shall I move on?
I think this is new learning and reinforcement. Slightly taken aback, but lot of learning points from this. Yeah.
Because we know that oxygen toxicity, even 6 hours of 100% oxygen in normal animals showed tracheitis and small airway injury and alveolar injury. Hyperoxia, as we know, causes reactive radical formation, which induces cellular injury, both endothelial and epithelial injury. And also, if you give 100% oxygen without nitrogen, 100% oxygen means zero nitrogen, then it causes absorption atelectasis because there is no nitrogen to keep the alveoli open because all the oxygen is utilized by the body. And of course, in neonates, it's well known, but it also happens in adults and older children, right? So that's why you have to minimize how much FiO2 you give quickly after you intubate. And only way you can do that is by fast and progressive increase in the PEEP. Or start with a higher PEEP, and once you get the FiO2 down to 40%, then start weaning the PEEP, right?
Right.
And CO2, which was a villain, 30, 40 years ago, we used to do blood gases every 3-4 hours when they are on ventilator. And we used to make sure that they get our PCO2 down to 35, 40. As a result, we might have caused a lot of lung injury, So now we realize there is no proven long-term side effects from hypercapnia. Unless, of course, you have increased ICP or pulmonary hypertension, where CO2 is bad. Otherwise, there is no harm to CO2. In fact, there are some studies to say that actually in ARDS, CO2 may be actually a good, because as you know, high CO2 is a pulmonary vasoconstrictor. So it actually decreases the permeability edema in the lungs. So it may be actually a good thing to have a little higher CO2. So bottom line is, don't chase your CO2 in the blood gas, right? Your primary aim is to keep him on oxygen, minimal oxygen, to achieve your oxygenation.
Okay, so how often would you do blood gas analysis, sir?
No, really, you don't need to. I mean, once you have the saturations on, probe on, even once a day should be okay. I mean, just to make sure. I'm more worried about alkalosis than acidosis. You know, sometimes what happens, the lungs start getting better and PCO2 going down to 20s and pH becoming 7.55. That is bad for the brain, actually, the low CO2. So that's why to trade, you know, and nowadays you also have, I don't know whether you are using it, nowadays you also have end-tidal CO2 monitoring.
That we do.
Right? So you really don't need to, really do too many blood gases. No, of course, the metabolic component of the blood gas, if there is a doubt, you have to do blood gases. There is no way you can know. From respiratory point of view, there is no need to do too many blood gases.
ETCO2. ETCO2 sensor is there.
Yeah, but
And
PAC
we
we
need
don't
to
use.
ask. We need to ask. Not for
Okay,
us.
sir. Yeah, so a lot of learning points, but
Yeah.
in NICU they're using, but in the pediatric ICU we don't use it. ETCO2.
ETCO2.
Even otherwise, I mean, as long as you don't need to chase too many blood gases, one or maximum two, and one blood gas is usually more than enough, unless there is a major shift. For example, suddenly his FiO2 requirement in the morning was 40% and now he's requiring 80%, then yes, you can do a blood gas. But for me, the blood gas in the ICU is more for metabolic component rather than the respiratory component. Because there is no way you can know metabolic acidosis by any other gadget, right? So yeah, that is why we need to know.
Right.
So now coming back to our patient, on day 2-3, he's reasonably stable. His ventilator settings are PIP of 26. Of course, when you say a PIP of 26, you should always look at the ventilator and see how much tidal volume is he getting. He's getting about 7 cc per kilo. PEEP of 10, respiratory rate of 24, I time of 0.7, FiO2 of 0.35. So he's weaned down nicely to 0.35 FiO2. Over the next 24 hours, his FiO2 requirement has gone up to 65%. This was day 2 and 3 was it, but next 24 hours, his FiO2 requirement has gone up to 65%. His ABG now shows 7.30, PCO2 of 60, and PO2 is back to 60s, which was there before, and base excess of plus 10. He's also having fever, your next step. So what do you think is going on? This is a typical thing in any modern ICUs. Huh?
They say hospital acquired pneumonia.
Could be there.
Absolutely, right? Ventilator associated pneumonia. His oxygen requirement has gone up. Probably if you have done an X-ray, X-ray will be worse, and fever. So you have to address that, right? So I'm not going to go into the detail of that because, you know, you take secretions, you broaden the antibiotics or start the antibiotics if you are not already done so. Yeah. So look for ventilator associated pneumonia. So you send off tracheal aspirates and then start him on broad spectrum antibiotics. That night you are called to say that suddenly he started having desaturations. His peak pressure alarm is buzzing. His tidal volumes are very low. On examination, there is decreased air entry on both sides. So what do you think is going on here?
They say
Tube?
Tube block.
Tube block, correct. Not tube displacement. Not tube displacement, right? Because the blood peak pressures are very high. If the tube is displaced to esophagus, the peak pressures will be low. So his tidal volumes are low. So this is a tube block. Usually your dope, correct?
Yeah.
You have to address the dope, right? Displacement, obstruction. Yeah. Yeah. So his ET tube is changed and now he's stable. Chest X-ray shows no pneumothorax. So next he becomes afebrile in next 72 hours. At the end of the 7th day, his ventilator settings are SIMV PIP of 26. Now it is giving him tidal volume of 10 cc per kilo. PEEP is 8, respiratory rate of 24, I time of 0.7, FiO2 35, and his blood gas is this. So is he getting better?
Huh? They say it's over-ventilated.
Yeah, so he's getting better, right? He's getting better in the sense the same pressures are giving him 10 cc per kilo, and
Yes.
his FiO2 is still 35%. His PO2 is 110. PCO2, which was 60, is now 35, right? So he's ready to be weaned. You can quickly wean him. You don't need to do step by step. He is probably even ready for extubation if you quickly, bring down the settings.
Yes.
So you decide to wean him. We wean him after 3 days of weaning. You don't need to do 3 days. And there is no need that you have to wean slowly. If his lungs are better, even 24 hours of weaning, or even just you can do trial of extubation, in the sense 2 hours, you can put him on CPAP and see what he's doing. If he's comfortable, you can take out the tube, because that is how we approach nowadays. There is no like set weaning that slowly you have to wean now. His ventilator settings are pressure support mode, pressure support of 10, PEEP of 4, FiO2 30%. He's generating a good tidal volume. He's breathing at a rate of 28, which is comfortable. Heart rate is 108. So he's ready for extubation, right? Agree?
Yes.
Yeah.
Yes.
Okay.
Yes.
So we put him, how do you extubate? That is another big talk anyway, weaning and extubation. But there is different ways of doing it. I mean, you can pick whichever way. You can just put him on CPAP. You can just put him on a little bit of pressure support, or you can even put him on TPs and just give oxygen and see how he is doing after an hour or 2 hours. And then you can extubate, right? So we'll not talk about how you want to wean and extubate, but yeah, you can do it whichever way you are comfortable.
Yes.
Okay, so any question about first case?
How to decide on how much PEEP should be kept initially? Because we are, as of now, what we are using is to go slowly with the PEEP, not to keep higher and to come down.
So then it just
Yes.
what
So
to know how to decide on the initial PEEP.
yes.
What people?
See, generally, if you see the if you see the X-ray and that it is completely white out ARDS lungs, which in this case it was, then personally I would start when I intubate this patient, I start them on a very high PEEP, 10 or 12, and make sure they get 6 cc tidal volume, adjust the PIP accordingly, and then, of course, when we intubate, we start on 100% oxygen. And within next 1 or 2 hours, I try to get a FiO2 down to 60 or 50% or 40%. And once I do that, I will start weaning the PEEP. I'm not saying that is the only way to do it. I mean, that's what I prefer, because for me, most important thing is to spend very little time on higher FiO2, because I feel that high oxygen is the most important culprit. Right?
Okay.
So it is better to increase a high PEEP and then come down. But of course, there are some people who start with 100% and a PEEP of 5, and then they try to reduce the FiO2 to 90. If the saturations come down with that, they increase the PEEP to 6 or 7, and then again try to reduce the FiO2. So basically titrating the FiO2 and the PEEP. You can do that way also. That's fine. But you have to do it quickly. You cannot leave him on a 70% overnight or 80% overnight or 100% overnight.
Right.
The aim is to get the FiO2 down quickly.
Yes.
Sir, PEEP of 12, is it not too high, sir?
How do you tell what PEEP is high? If you have a very severe lung disease, even PEEP of 15 is not high.
Yes.
See, as I told you, it all depends on the balloon analogy I gave you, right? It all depends on how stiff the balloon is. If the balloon is very compliant, normal balloon, thin balloon, even PEEP of 8 can break it. But if you have a very thick balloon inside a rigid tube, even PEEP of 15 will not break it. Correct?
So in these scenarios like ARDS, what would be
Yeah.
the ideal PEEP to keep at beginning?
Yes. So ideal, there is nothing like an ideal PEEP for, I mean, in general, it all depends on how bad the lung disease is. So there are a few
Means-
ways of titrating the PEEP, right? How do you titrate the PEEP? Basically, you titrate the PEEP to PEEP of best compliance. So how do you know the compliance? How do you calculate compliance? What is compliance? We talked about last time, right? Delta V by delta P. Correct?
Correct.
Change in volume divided by change in pressure.
Yes.
Now, suppose you have a PEEP of 8 and say, let us say PIP of 28. So 28 minus 8 or plateau pressure of 28. 28 minus 8 will give you a delta P of 20. Now, let us say it is giving you a tidal volume of 100 ml.
Mm.
Now, in the next, after half an hour, you make PIP go up by 2 and PEEP go up by 2. So that means delta P is the same. Correct?
Correct.
But if with that delta P, if the tidal volume is better, that means what? You have improved the compliance by increasing P. Correct?
Correct.
Yes.
I wish I was physically there so that I can use the blackboard. But anyway, so but I hope you're following.
Yeah, absolutely.
So basically, you need to find what is the PEEP of best compliance for that particular patient, particular lungs. There is nothing like, I cannot give you a statement that, oh, PEEP of 15 is bad. No, or bad for whom? For example, if I have a patient who is undergoing surgery for something else and he's routinely intubated, if I give him a PEEP of 15, definitely it is bad for him. But not for the patient who has a bad lungs.
Right.
So there is nothing like a optimal PEEP. Optimal PEEP is for particular patient. There is no general statement that this is optimal PEEP. You got my point?
Yes.
Yes.
Yeah.
There's some
So one way of knowing is to do PEEP of best compliance by changing the PIP and PEEP, keeping the delta P same, and then looking at the tidal volume with that delta P. Where the tidal volume is the best, that is the PEEP of best compliance. That is one way of doing it. There are other people who do PEEP of best oxygenation, in the sense they have, say, FiO2 of 80 or FiO2 of 70. You keep on increasing or decreasing the PEEP and see at which point the oxygenation is the best.
Okay.
Correct? That is one way of doing it.
Right.
Yes.
Any
Yeah.
other questions so that we can go to the second?
We can go to the second, sir.
Okay.
Points will.
Second, yeah. Okay. So this is an 18-year-old child with known asthma, comes with a severe exacerbation. He has been treated with IV steroids, continuous nebulization, IV aminophylline for last 12 hours. He's in severe distress and his saturations are 83% on 15 liters oxygen. Right? You decide to intubate. You intubate him using ketamine, succinylcholine. 5 minutes after successful intubation, he had a cardiac arrest. I mean, again, this is a real case. This is a real case. Huh? I mean, it is not very uncommon, actually. It is very common even in adults with COPD. This is very, very common. That's why, I mean, it's important to know, right? So what happened here? What do you think happened? What do your PGs think happened here? Why? I mean, you were supposed to help him with intubation, but you caused a cardiac arrest for him. What happened? And tube is in. We have checked with the end-tidal. Tube is definitely in. You are not done esophageal intubation. Tube is in.
Okay.
So,
they say-
any thoughts why it happened? Sorry?
5 minutes after successful intubation, he had a cardiac arrest.
Correct.
So, is it because of scoline, succinyl choline?
No, scoline. No, not scoline. Okay, I will take out the scoline. I will say rocuronium. Okay, still he had an arrest. No, not scoline. No.
Is it because of severe hypoxia that set in?
Why did he become hypoxic? You were supposed to help him with oxygenation, right? With this, why did he become hypoxic? I mean, he should have oxygenation should have got better. It is not because of hypoxia.
Is it because of aminophylline?
No,
Mm,
he was on aminophylline for last 12 hours.
mm. I don't know.
Okay,
Is it
let's see what
because of-
happened here, right? Because of
Don't know.
okay. Any other thoughts? Sorry?
Any, did not think about the parasympathetic. I don't know.
No, okay, let us say he was given atropine also. No, not related to that. This is a very important physiology. We will go through that.
Yes.
Could we have done better? Definitely we could have done better. Now, okay. We will come to that, why it happened later, right? When we discuss this case, we'll come to that, why it happened. Then you will realize why it happened. Now, please remember, this is an obstructive lung disease, as opposed to the restrictive lung disease we talked previous case. Previous case was ARDS, kerosene, so that is a restrictive lung disease, whereas this is an obstructive lung disease, purely obstructive lung disease. There is no problem with the alveoli. All the problem is in the small airways. Now, you remember, intubation and ventilation do not assist the basic problem in asthmatic. Basic problem in asthmatic is expiration. And we talked about last time, there is no ventilator which supports exhalation. Correct? Now, that is why intubation and ventilating an asthmatic actually does not change the basic problem the asthmatic has, which is exhalation problem. But still, we may have to intubate, because otherwise, with 83% saturations, this patient would have become very tired and would have arrested on you without even intubating, right? So definitely, we do intubate. Sometimes we may have to intubate asthmatic for sure, but please remember, it does not address the basic problems. So, in fact, when you paralyze these patients for intubation, you know how the asthmatics exhale, right? They use all sorts of accessory muscles to exhale. Sternocleidomastoid, accessory expiratory muscles, everything they use to exhale, because there is a airway obstruction. But when you take that away by paralyzing them, you are actually may make it worse, right? So ventilating and intubating an asthmatic can actually a problem rather than a solution. That's why it is much easier to ventilate an ARDS patient than a bad asthmatic patient. Because in asthma, the problem is exhalation, and ventilation does not solve that problem. In fact, it may make it worse, because you are taking away the accessory muscles of exhalation, which are important for exhaling against an airway obstruction. And of course, ET tube itself can provoke bronchospasm. Anything in the throat or in the airway can provoke bronchospasm, right? So that is why we try not to ventilate or intubate an asthmatic as much as possible. And we have so many things, in the sense we have bronchodilators, inhaled bronchodilators, IV bronchodilators, we have magnesium, we have steroids. We should pour in everything in a severe asthmatic quickly, not stepwise, quickly, so that you don't have to come to a situation where you have to ventilate an asthmatic, right? Why is that? We will go through this. So that is why nowadays we do more of non-invasive ventilation in asthmatic pretty early, in the sense you are nebulizing him, you are giving magnesium. If he's in a lot of distress, rather than thinking about intubating, you can even put him on non-invasive ventilation. Not that is going to help his exhalation, but at least it will take away his work of breathing on the inspiratory side, so that he has more strength to exhale, right? So basically to prevent fatigue. This also still doesn't address the problem of exhalation, but it will take away the work of breathing, the inspiratory part, right? And of course, the tube is not there, so airway irritation is avoided. So that's why we do more of non-invasive ventilation. Now, coming back to how do you intubate an asthmatic? We did, this patient was also intubated using ketamine. Why ketamine?
It has bronchodilator.
Why not propofol? Why not fentanyl? Why not morphine? Ketamine is a good bronchodilator, right? So that's why ketamine is a good medication to use for intubating an asthmatic. And if you are really well versed with intubation, even awake intubation with local anesthesia also may be an option, so that you don't need to paralyze him, so that he has his own external, expiratory muscles to use once you intubate. Okay, so we properly ventilated, intubated him. We used ketamine in this patient. We used Cycolin. Lidocaine was not used. Lidocaine because to take away the irritation part in the throat, which causes reflex bronchospasm, which was not used, which was okay. I mean, you don't need to, right? Okay. So what is the problem in, let us look at what happened here. Before that, let us look at physiology of what happened here, right? Now, main problem in asthma or COPD or in BPD is your airway obstruction, right? So in airway obstruction, when there is an airway obstruction, what happens? If there is an airway obstruction, progressively the alveoli become increasingly bigger and bigger. And so there is a rise in end expiratory pressure, correct? Now, what are the predisposing factors? For example, if you have a long inspiratory time, for example, if you ventilate this patient and put them on long inspiratory time, not giving enough expiratory time, that will worsen the gas trapping. If you put them on high respiratory rate, automatically, if you put on high respiratory rate, your expiratory time will become shorter. So he does not have enough time to exhale. So that predisposes to gas trapping. So this is what happens with the gas trapping. The end expiratory volume, that is hyperinflation. I mean, gas trapping, auto PEEP, or hyperinflation, they're all same terminologies, basically. So when you have a high, hyperinflation, what happens? Increases the intrathoracic pressure and it decreases the venous return. Yeah. So when it decreases the venous return, what happens to the cardiac output? It decreases. Now, also, because of hyperinflation, all the blood vessels in the alveoli get squished. So there is ventilation, but there is no perfusion there. That is increased dead space. So that causes abnormal gas exchange. And also, we talked about talked about the graph last time, right? When you increase the functional residual capacity, it increases the pulmonary vascular resistance also. And increased resistance also causes increased work of breathing. So all these are happening in a severe asthmatic.
Yeah.
Of course, if it stretched further, there will be air leak, pneumothorax, and all those things, right? Yeah. Sorry, any questions so far?
No, fair enough, sir.
Yeah.
Yeah.
Okay. So now, let us say he did not have a cardiac arrest. We'll come back to that, why he had a cardiac arrest later. So, okay, let us address it, why it happened cardiac arrest here, because now since we know. See, what happened here in this patient? He was breathing, we're using all the accessory muscles. Now you paralyze him and intubate him. And most of the times, when you intubate, if the desaturations are there, what do? You start bagging them. You are panicked. Yeah. Person who has intubated has panicked. They start bagging. So when you start bagging like that, what is going to happen? He has no, this his intrathoracic pressure keeps on increasing because you're not giving enough time for him to exhale. Correct? So what happens to the cardiac output? It decreases, and it decreases so critically that he ends up having a cardiac arrest. So this patient had cardiac arrest because somebody has bagged him vigorously. So the key teaching point, when you intubate an asthmatic, when you intubate a patient with COPD, or when you intubate a patient with, say, BPD, we don't see much BPD nowadays, but when you intubate a patient with bronchiolitis, do not over vigorously bag them. In fact, adults say you start bagging them at a rate of 4 or 6. That's it. Adolescent, 18 years, maybe 6 or 8. That's it. You, in fact, some people advise after intubation, you press on the chest to exhale for them. Because as I told you, their problem is exhalation. And you have taken away their active exhalation by paralyzing them. So you got to assist them. So this patient had a cardiac arrest because of the decreased cardiac output, not because of hypoxemia, not because of drugs, not because of hypercapnia. It is purely because of decreased cardiac output due to massive air trapping. Make sense?
Right. Yeah.
So what is the clinical point? The clinical point is when you intubate such patients, you can get away with this in ARDS. You can bag them 30, 40 per minute, nothing happens. But a patient with obstructive lung disease, when you intubate them, be very slow and big volume, but slow breaths, and giving enough time for exhalation, or even assisting them passively by compressing the chest to exhale. This is a very, very important point. Second, also, if you have a time before intubating, also give them a fluid bolus so that they are not dehydrated, because this can get worse if they're already dehydrated. If they're dehydrated, their venous return will be less, cardiac output will be less. And if you increase the intrathoracic pressure, they're going to have less cardiac output, and critically less cardiac output means cardiac arrest. So give a fluid volume, make sure that they're well hydrated. When you intubate them, don't be vigorous, take it easy. Saturations are 80, 85 is not going to kill them. What is going to kill them is the decreased cardiac output. Yeah?
Yes.
Okay. So now he is on a ventilator. Now let us say he survived. You resuscitated him. His ABG shows PCO2 of 72, PO2 of 120. He's on volume when limited mode, rate of 20, tidal volume of 400, I time of 1.2 seconds, PEEP of 0. He begins to come off paralysis and is struggling with the ventilator. You paralyze him. His repeat ABG shows PCO2 of 190. PCO2, not PO2. PCO2 of 190. So what do you think what happened here? Was it the correct settings you choose? Any comment about the settings?
I time is too high. I would keep at 0.6
So rate
or
of 20, correct. Rate of 20 means 3 seconds is the cycle time. I time is 1.2, so E time is 1.8. So 1:1.5, which is very, very low. That means you're not giving enough time for the exhalation. Correct. Right? So even rate, so how do you change that? So one is you can reduce the rate to 15 or 14, one. I time you can reduce to 0.8. And in these kids, 1:2 is not enough. You may have to give them 1:3, or even 1:3.5, or even 1:4 sometimes. You know, it's okay to give 1:4. Right?
Right.
And PEEP of 0, is it a good idea?
No.
Physiological peak, at least 4.
We will come to that. We'll come to that, whether it is a good PEEP or not. Huh? And then he begins to come off the paralysis and is struggling. You paralyze him again, and his repeat ABG shows PCO2 of 190. So obviously you're not helping him. That is because your settings are not right. Right? Okay. So what went wrong here? The settings. Settings were not right. So Next 3 slides are very important. Let us understand this now. This is airway pressure with normal breathing. Let us say this tube is all the airways, that is small airways, trachea, everything in one compartment. This is another compartment of alveoli, this one. And this is the pleura, pleural pressure, right? And now let us say this is end expiration, right? Normal breathing. Normally what we are doing right now at the end of expiration, pleural pressure is 0, at the mouth is 0, so there is no air movement, right? Correct? This is atmospheric pressure, 0. This is normal, what we are doing right now. Normal person breathing, So this is at the end of expiration. Now, let us say this is beginning of inspiration. What happens in normal people? We create a negative pleural pressure. You can see you can track my, this thing, no?
Yes.
You can track my, yeah, okay. The cursor, -5. So beginning of inspiration, it is -5. That is why the air moves from here, mouth, which is atmospheric, which is 0, to the lower pressure, which is -5. That is how we breathe. The air moves into the alveoli. This is how we breathe normally. Now let us look at patient with asthma. Patient with asthma, what happens? As I told you, alveoli keep on hyperinflating. So what happens to the peak pressure? Positive end expiratory pressure at the end of expiration. This is end of expiration in a patient who is asthmatic. They have a high positive end expiratory pressure, and they have not yet completed the exhalation. They have not completed the exhalation. And pleural pressure is +6 because the alveolar pressure is +6. This is end expiration. Now let us say how when he starts taking a deep breath. Sorry. When he has to take a breath, what do you think he has to generate in the pleura to create air into the alveoli? How much force he has to generate?
Lot.
-7, right? -7. That means from +6, he has to go to -1. That is the only time the air will come from atmosphere into the patient. Correct?
Yeah. Correct.
Got my point?
Yeah.
So that means there is a lot of, he has to create a lot of effort in order to breathe in. So that is because of this, what we call as auto-PEEP. This auto-PEEP is related to the hyperinflation or the gas trapping. These are all the same terminology: auto-PEEP, hyperinflation, gas trapping. Because of this gas trapping, the next breath is much more difficult because he has to generate so much of negative pressure. He has to generate at least -1 to create a gradient from 0 to -1. But to create -1, he has to create -7 because he's already at +6. Correct? So suppose you paralyze him. How is he going to generate -7? He's not going to generate the -7. Correct?
Yes.
He's not going to generate -7 if you are going to paralyze him. Correct?
Correct.
So that is why when you paralyze these patients, they do much worse. So which mode is better for this patient? Support mode is better than the control mode. Of course, when you intubate, you have to give paralytics. So when you are paralyzed, make sure that you do slow breathing for them. And once they come off the paralysis, that's why we use very short-acting paralytics like scoline, so that they can quickly come off the paralysis, so that they can breathe on their own. They can set their own I time and E time. That is the support mode. Pressure support mode is better than the control mode in these patients.
Yes.
And also during support mode, patient can maintain their own exhalation. They can use their accessory muscle to exhale. Whereas any other mode, exhalation, any ventilator, the exhalation is passive. So if you paralyze them, the exhalation will be passive.
Correct.
So that is why we do pressure support ventilation strategy in asthmatics, particularly immediately after they come off the paralysis for intubation, right? And when you paralyze them, how much PEEP do you have to give? We talked about how much PEEP was necessary. That child was on a PEEP of 0 and he was struggling. Why? Because his PEEP was 0. Sorry, his PEEP was 0 and his pressure here was +6 and he was struggling because he could not generate -7. Whereas if you give a PEEP of 6, that means you are putting a pressure of 6 here at the endotracheal tube, and this is equalized to the pleural pressure. Now he has to generate just -1 to create a gradient. So that is the advantage of adding PEEP even in this patient.
Right.
You got the point?
Yes, yes, yes.
So PEEP was important for him because PEEP was 0, he was struggling. And if you had put a PEEP of 6 when he was spontaneously breathing, he could have been much better. Okay. So how do you manage the auto PEEP? Basically, you add the extrinsic PEEP, similar to the auto PEEP. How do you determine how much auto PEEP he has? We talked about last time how to measure plateau pressure, right? So how do you measure auto PEEP?
Put him on inspiratory hold and see.
Expiratory hold. Inspiratory hold was for plateau pressure.
Sorry, yeah, expiratory hold.
This is expiratory hold, right? At the end of expiration, you measure the auto PEEP and you supplement the auto PEEP or similar to auto PEEP you put him on so that he doesn't need to do that struggling part. And of course, how do you reduce further hyperinflation? We talked about decreasing the respiratory rate, prolonging the expiratory time, increasing the inspiratory flow. All these things we should change on the ventilator when you are managing a patient with obstructive lung disease.
Yes.
Of course, immediately after intubation, when you are paralyzed, you can use controlled ventilation strategy. That means he's not breathing on his own. Then PEEP of 0 may be okay for a while because he's not breathing on his own. So there is no way he needs to trigger the breath. But once he's off paralytics, he's breathing on his own, you should make sure that the PEEP is matched to the auto PEEP. I hope I'm not too fast and I'm not too confusing.
No, sir.
Okay.
Going on perfect.
Yeah. Again, here also, as I told you, high CO2 never kills an asthmatic. What kills an asthmatic is usually hypotension because of the phenomena I explained to you, and also hypoxia. Don't worry about the CO2 part. Hemodynamics is what is going to kill them immediately after intubation. So we talked about this already. I'm not going to go to the in detail, but again, want to reiterate two things. Peak pressure is what you measure at the end of endotracheal tube. Alveolar pressure is by inspiratory hold. You measure that gives you an estimate of alveolar pressure. The pressure difference is the resistance. So why am I putting up this slide is because, for example, a patient with ARDS, you are doing ventilation with volume ventilation and you see that his peak pressures are 40 or 45. That's not a good sign because that means that tells you that his lungs are really bad. Whereas in an asthmatic with the same tidal volume, same weight patient, asthmatic, pure asthmatic, if peak pressures go to 45, 50, I'm not so much worried. Why I'm not so much worried? Because I know that is because of the airway problems. And I have a lot of therapies to resolve the airway problem. Bronchodilators, steroids, magnesium, all those will fix this problem so that in few hours he will be much better, right? Till then, I can accept the little higher peak pressures. Whereas in ARDS, peak pressures of 45, 50 usually tells you that it is really bad lungs. Whereas in an asthmatic, it will tell you that it is a bad obstruction, but you have something to do about it, right? So that is why these pressures in the context of the patient you have to look at. So when you minus the plateau pressure from peak pressure, if the gradient is very little, that tells you that it is a lung disease. If the gradient is too much, it will tell you that it is a airway disease.
Yes.
So how do you treat an asthmatic? Early use of NIV, awake intubation so that he don't need to use paralysis, but awake intubation requires expertise. So if you have not tried it before, don't try it because it is only going to cause more bronchospasm if you don't do it quickly. Very slow bagging, very, very important. Very slow bagging, even active expiratory assist by pressing on the chest. Prior volume loading so that he is not dehydrated to start with because more chances of hypotension. And of course, there can always be tension pneumothorax as a cause for hypotension. So you should always remember that, if there is bilateral air entry is, one side air entry is not there, the other side air entry is there, make sure there is no pneumothorax. Use lowest possible rate, highest possible IE ratio, and remember to match auto PEEP with extrinsic PEEP and use support mode of ventilation whenever possible.
Yes.
Okay, quickly few slides because again, I think we have run out of time already, 1.5 hours. Other scenarios, how do you ventilate a head injury patient, status epilepticus patient, cardiogenic shock, neuromuscular disease, post-operative ventilation, just one slide each. A head injury, when you intubate these patients, use drugs which decreases the increased intracranial pressure, like pentobarbital or propofol. Those are better drugs. Use lidocaine. IV lidocaine can be given 2-3 minutes before the procedure so that by doing the laryngoscopy itself, increases the ICP reflexly by stimulating the glossopharyngeal nerve. Lidocaine either locally or IV actually anesthetizes the mucous membrane. So it will reduce the ICP surges. Keep PCO2 around 35 throughout. So that is why in this particular case, probably volume ventilation would be better because you have better control over ventilation. So PCO2 is around 35 unless there is impending herniation, then you can hyperventilate and bring the PCO2 down to 25-30 transiently. Otherwise, keep it around 35. Volume ventilation preferred because as I told you, it gives you a better control over CO2. Keep physiologic PEEP, sedation and paralytics because if he's struggling with the ventilator, his ICP is going to go up. So sedation and paralytics if necessary, if the patient is struggling. Status epilepticus, same pentobarbital because it's a very good anti-seizure medication. So you can use that for intubation. Keep PCO2 normal, 35 to 40. Volume ventilation preferred for the same reason so that you know what the CO2s are. You don't want them to be alkalotic or acidotic. So you have a better control over those gases. So here you're not talking about lung disease. So it is okay to ventilate them with the volume ventilation. Keep physiologic PEEP and sedation. Cardiogenic shock, it's again, cardiopulmonary interaction is a whole talk by itself. But remember, positive pressure ventilation reduces the afterload on the heart. So always, if a patient has cardiogenic shock, ventilation helps by reducing the afterload. Again, there's just one statement I've given, but this is a whole talk how the cardiopulmonary interaction works because positive pressure ventilation definitely decreases the venous return we talked about. So that is bad for the heart, but it also reduces the afterload on the heart, which is good for the heart. So in a net situation in cardiogenic shock, ventilating will help because not only it reduces the afterload on the heart, it also takes away the work of breathing, right? So that is significant less work on the heart also, workload on the heart. Neuromuscular disease, of course, if you are ventilating a patient with Duchenne's muscular dystrophy, always try NIV because they're very, very effective particularly for neuromuscular kids because they don't require usually high pressures. All they need is very little pressure because their muscles are very weak. So their chest wall compliance is very good. So you can easily ventilate them with NIV. And sometimes we have sent patients on NIV home for Duchenne's muscular dystrophy. But of course, you have to make sure that their reflexes are good because, for example, a child with Guillain-Barré syndrome, you can say, okay, can we try NIV? You can try NIV, but the problem with Guillain-Barré also sometimes is they don't have a good cough and gag. So if you are on an NIV and they vomit, they're going to aspirate big time. So you got to make sure that, these are usually contraindications for NIV. They have to be able to manage their airway very well, then only you can use the NIV. Whereas Duchenne's usually have no problem. At least their cough may be weak, but they still can protect their airways. So, and also extubation should be well planned in neuromuscular disease because their muscles are very weak. So when you extubate them, make sure that, you should extubate them to NIV and then slowly transition them because suddenly impose a lot of work on their respiratory muscles, they may fail. I think post-operative ventilation is very easy. I mean, most of the time their lungs, heart are okay. It's a routine post-op ventilation. So once they are awake, make sure that they're hemodynamically stable. They're not bleeding anywhere, so that you don't need to take them to OT again. So once you make assured of all those things, then you can extubate them. So I just put 4 or 5 slides because predominantly it is ERDS and obstructive lung disease. That's where you have to be very, very thorough in the physiology, understanding the physiology, so that you use it properly. The rest of the things are, can be done. Yeah. So, few philosophy. First of all, when you remember, no ventilator has saved any lives. Okay, ventilator only gives you time so that whatever else you do will save the patient's life, and you're only buying time with the ventilator. So don't do any damage further to the patient by using the ventilator. So the predominantly do no harm, that is applicable to the ventilator also. Eliminate barotrauma, use minimal oxygen, and your purpose of ventilating anybody is to decrease the work of breathing and to keep them alive. So you don't have to have 100%. You don't have to have normal PCO2. So accept, nowadays even we are talking about permissive hyperxemia also, so that you don't damage the lungs further. Accept even 90, 92 saturations. Accept higher CO2 as long as the pH is good. So basically do no harm, right, while we're ventilating a patient. So the entire paradigm has shifted in last 30 years ventilating. We used to target normal blood gases. Now what we target is minimizing the ventilator-induced lung injury by minimizing the pressures, minimizing the FiO2, which we are using to ventilate. I guess I'm right on time, Vikram.
Yes, sir, absolutely. It was riveting. I think lot of learning points. I'm sure.
Your voice is breaking, Vikram. I can't hear you.
I'm sure our postgraduate students have learned quite a lot, because for me, it was like a new lesson, because I don't do.
Vikram, break ಆಗ್ತಾ ಇದೆ voice ಕೇಳಿಸ್ತಾ ಇಲ್ಲ.
Oh, that. I'll just. Is it better? Any better now? Is it
better? Little better.
Is it better, sir?
This is better.
But the only thing is slightly echoing.
ಅದೊಂದು ಏನೋ microphone ಇದ್ರೆ you put the microphone.
So